Hi, I'm Dr. Siddharth Prakash from the University of Texas Health Science Center at Houston. I'm Associate Professor in Internal Medicine. I've been asked to tell you briefly about an ambulatory blood pressure study at our institution and the ways that we're addressing blood pressure for our patients with vascular disease. Ambulatory blood pressure monitoring is abbreviated as ABPM. The components are shown in this picture. There is a cuff that is just similar to an office blood pressure cuff attached to tubing and a device recorder that the patient can wear in their pocket. This is carried around for 24 hours and returned to a clinic where it can be downloaded into a computer. Software there can interpret the blood pressure readings and lead and create a report that we can then provide to patients and providers who refer them. The patient also writes a diary of their activities so that we can correlate blood pressure with activities and medications. This is a simple and affordable way to get very detailed readouts of a patient's blood pressure. It's tolerable to most patients because there are comfort settings that are designed to allow it to be used 24 hours a day. And it provides immediate and powerful feedback about blood pressure that can really be used to change therapies and alter your perceptions about a patient's disease status. Unfortunately, it's not yet widely available because the insurance reimbursement is very low. We are hoping to change that, and in the future, it should become a gold standard for measuring hypertension. Why ABPMs? Well, it turns out that office blood pressures misdiagnose up to 1/3 of hypertension cases, either by failing to diagnose hypertension when it's present, so-called masked hypertension, or by diagnosing hypertension when it is not present. And either scenario can be very bad for the patient, either undertreatment of hypertension, leading to increased complications, or overtreatment, where hypertension is not actually present and not needed, and this can result in severe side effects. So it is very important to get this right. And when we're dealing with patients with vascular diseases like VEDS, hypertension and its treatment can literally be matters of life and death. So we need to get this right. In order to do this, we need to have as much data as we can so that we are making informed decisions. On the right here, I'm showing you a graph of the ability of ambulatory and office blood pressures to predict the most common complication of hypertension, which is enlargement of the left ventricle of the heart. It turns out that in all scenarios, 24-hour blood pressures provide superior ability to detect end organ damage related to hypertension than single office blood pressure measurements, no matter how well controlled they are. Therefore, it makes sense that it should also be able to detect, be used to risk stratify patients who are at risk for dissections. This is what a typical 24-hour blood pressure looks like. As on the left, you can see the blood pressure readings in millimeters of mercury, and across you can see the blood pressure variance over 24 hours of time. What you can notice is both systolic and diastolic pressures vary quite a bit. They're dynamic, and along with heart rate, they have diurnal variations, some of which are predictable. The most predictable aspect of blood pressure in most healthy individuals is a drop or nocturnal dip at night during rest, and a morning surge when one awakens. However, in disease, this can be markedly abnormal. This shows an example of the variation in a 24-hour pattern. Everything from an extreme dip in which the blood pressure actually becomes hypotensive at night to a patient whose blood pressure actually rises at night. And these categories have been used in other clinical contexts to predict cardiovascular disease outcomes like MI, stroke, and sudden death. It turns out that people who have an abnormal rise in blood pressure at night are have an extremely high risk, up to 5 times, of dying from cardiovascular disease. The reasons behind this are complex, but the point is that ABPMs can provide independent data to risk stratify patients beyond traditional clinical factors. This shows in a study of around 75 patients who survived aortic dissections, who were measured using 24-hour blood pressure. And what it showed is that the timing of their clinical event, as based on clinical records, varies with their dipping status. That is, those patients who did not have blood pressure dips at night tended to have their dissections during the nighttime, whereas those who dipped normally dissected during the day. And this is clinically important because nighttime dissections are associated with higher mortality. So the ability to predict this and potentially treat or prevent these dissections becomes very important. So this is a summary of the prognostic information we can gain from 24-hour ABPMs. We can diagnose nocturnal hypertension, which we would not otherwise suspect. We can diagnose episodic or exertional hypertension, autonomic nervous system function, indicators of vascular stiffness, even sleep breathing disturbances based on blood pressure rises during sleep, and most importantly, the efficacy and timing of medical therapies for hypertension. I'm going to show you with a few examples from our patients. This individual has stage 1 hypertension during the day, but normal dipping at night, the night in purple and the day in white. This is a classic example of someone with treatable hypertension that is fairly constant during the day. In contrast, this individual has the opposite pattern. You can see that during the daytime on the left, their blood pressures are fairly normal as indicated by that purple band, which is the normal range. And at nighttime and on the right, their blood pressures rise dramatically into the moderate hypertensive range. This is reverse nighttime dipping, and this indicates an individual who may either have underlying cardiovascular disease or sleep disordered breathing, a common trigger for this. This individual had normal blood pressures when the ABPM was placed on the left, but you can see that they rise dramatically with exercise as indicated in their diary in the middle of the day, and then fall back to normal by nighttime. This is episodic hypertension, probably triggered by exertion with intact nocturnal dipping. And this individual, if they wanted to pursue an exercise program, would need to have their blood pressure well controlled prior to embarking on one. And this is one of the more common patterns we see clinically. A patient who, when the ABPM is placed in clinic, was very hypertensive, but essentially returned to normal when they were at home. This is white coat hypertension, a common cause related to anxiety in the clinic, and treatment of this based on clinic blood pressures would result in overtreatment of hypertension that really isn't needed, potentially placing the patient at risk for side effects. So the outstanding questions related to VEDS in particular and other types of vascular diseases are, do abnormal ABPM patterns predict vascular events in VEDS? Can we use ABPM data to assess the efficacy of antihypertensive medications and optimize doses? I hope sincerely that this is a question that is addressed in upcoming clinical trials of medications in VEDS. How do surgical interventions affect ABPM responses? And how does the underlying genetic mutation affect ABPM patterns? We are currently enrolling patients in these studies and in additional studies related to exercise. Please contact me if you have any questions. Thank you.